Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 141 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, TMT, a 35-year-old female patient had a motor vehicle accident, during which she sustained serious chest and brain injuries which merited intubation and mechanical ventilation prior to admission to the trauma ICU. She has already spent 4 days in the ICU. This morning her chest X-ray showed a new infiltrate, maximum body temperature of 38.8 degrees Celsius, WBC of 15 × 10⁻³ cells per millimeter cubed. She is producing macroscopically purulent sputum. She is dynamically stable. A bronchoalveolar lavage, BAL, of the affected lung field is done to assess for VAP. So my question to you is, which of the pathogens listed below is the most likely cause of TMT's VAP? Is it A. Streptococcus pneumoniae, or B. MDR Pseudomonas aeruginosa, or C. MRSA, or is it D. Acinetobacter species? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Streptococcus pneumoniae. The patient described has early onset VAP without apparent updated risk factors for MDROs. Answers D, B, and C are all incorrect. Pathogens associated with early onset hospital-acquired pneumonia and VAP are usually community-acquired organisms, including Streptococcus pneumoniae, MSSA, Haemophilus influenza, and enteric gram-negative bacilli. That makes answer A correct. Although guideline updates recommend that Pseudomonas aeruginosa coverage be considered as empiric therapy for all patients suspected of VAP, lack of MDRO risk factors decreases the likelihood of MDR strains. Atypical bacteria are rarely associated with early onset VAP. If MDRO risk factors were present, MRSA and Pseudomonas aeruginosa would also be considered. Let's move to the next question please. And the next question reads, considering the 2016 IDSA guidelines, which empiric antibiotic regimen listed below would be the most effective for the likely causative pathogen or pathogens of TMT's suspected VAP? Would it be A. Ceftriaxone plus vancomycin, or B. Ceftriaxone, or C. Cefepime, or would it be D. azithromycin plus moxifloxacin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Ceftriaxone. Empiric antibiotic choices for VAP should be based on the likely causative pathogens, the presence of MDRO risk factors, and local antibiotic susceptibility patterns. Ceftriaxone is a reasonable agent for empiric management of early-onset VAP with activity against common pathogens. That makes answer B correct. Broad-spectrum regimens would provide adequate coverage but would result in an unnecessary breadth of antibiotic exposure. That makes answer C incorrect. Empiric monotherapy for gram-positive organisms is insufficient. That makes A incorrect. Atypical bacteria are rarely associated with early-onset VAP. That makes answer D incorrect. Let's move to the next question, please. And the next question reads, JTD, a 55-year-old male patient is admitted to your MICU, following a diagnosis of severe hyperosmolar hyperglycemic syndrome. The intensivist places a subclavian CVC on his arrival at the MICU. 4 days into his MICU admission, JTD has a body temperature of 39.2 degrees Celsius, a WBC of 17 × 10⁻³ cells per millimeter cubed. His primary nurse notices a new erythema at the CVC site. An appropriate diagnostic workup is done. The team decides to initiate empiric antibiotic therapy for a suspected central line-associated bloodstream infection, abbreviated as CLABSI. So, my question to you is, which of the antimicrobials listed below would be the most appropriate empiric therapy for JTD now? Would it be A. vancomycin, or B. piperacillin, tazobactam, or C. linezolid, or would it be D. cefazolin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. vancomycin. Gram-positive organisms are the most common cause of CLABSI, including MRSA and MRSE. Vancomycin is the best option listed for empiric management. That makes answer A correct. Although linezolid has a sufficient spectrum of activity against these organisms, it is not recommended for empiric management of CLABSI because of concerns for worse patient outcomes. That makes answer C incorrect. The other options are inactive against MRSE and MRSA and could be considered in addition to vancomycin if there were a high suspicion for additional pathogens. That makes answers D and B incorrect. Let's move to the next question, please. And the next question reads, POB, a 33-year-old female patient is admitted to your MICU due to severe respiratory failure and ARDS. She requires intubation. She has complained of malaise, myalgia and fevers for 2 days. At the accident and emergency department, a nasal washing was sent for rapid diagnostic testing which turned positive for influenza A. In your institution, the prevalence or subtype 2009 H1N1 is considered high. So my question to you is, which of the therapeutic regimens listed below would be most appropriate for initial treatment of severe influenza in POB's case now? Would it be A. Oseltamivir, or B. IV zanamivir, or C. Inhaled zanamivir, or would it be D. amantadine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. O. Celtamivir. Given the high prevalence of the 2009 H1N1 subtype of influenza A, O. Celtamivir is the empiric drug of choice. Additionally, O. Celtamivir has high-level activity against other contemporary influenza A and B subtypes. That makes answer A correct. Zanamivir also has high-level activity against these strains, however inhaled therapy through the mechanical ventilator is not indicated because of insufficient systemic delivery, and IV zanamivir is available through compassionate use and indicated only if oseltamivir cannot be administered, e.g., patient is unable to receive enteral medications, has poor absorption. That makes answers B and C incorrect. Amantadine has insufficient activity against most contemporary influenza A and B strains. That makes answer D incorrect. Let's move to the next question, please. And the next question reads, JOJ, a 76-year-old female patient was admitted to the MICU for respiratory failure due to untreated severe community-acquired pneumonia. JOJ has had a urethral catheter in situ for 6 days while mechanically ventilated. During this period, the ICU team administered fentanyl infusion and intermittent haloperidol as needed for pain and delirium, respectively, to her. Today, in the morning, JOJ's temperature was 38.7 degrees Celsius and WBC was 60 × 10⁻³ cells per millimeter cubed. JOJ is hemodynamically stable. Her primary nurse sends blood and urine cultures to the microbiology lab. Later that day, urinalysis reveals significant pyuria. So my question to you is, which of the pathogens listed below is most likely to cause a catheter-associated urinary tract infection (CAUTI) in JOJ's case? Is it A. Staphylococcus aureus, or B. Pseudomonas aeruginosa, or C. Escherichia coli, or is it D. Enterococcus faecalis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Escherichia coli. Although a healthcare-associated CAUTI is caused by a more diverse spectrum of pathogens, Escherichia coli is still the most common pathogen and is responsible for around 30% of cases. That makes answer C correct. The other pathogens listed are also possible and should be considered when choosing empiric antibiotic therapy in patients with a suspected CAUTI. That makes answers A, B, and D incorrect. Let's move to the next question, please. And the next question reads, TMP, a 54-year-old male patient is admitted to your SICU following emergent surgery and partial bowel resection with primary anastomosis for mid-small bowel necrosis and perforation likely secondary to severe peripheral vascular disease. During surgery, there occurred significant peritoneal contamination with clear evidence of gross peritonitis. TMP had persistent hypotension. He needs vasopressors. He received perioperative cefazolin and metronidazole intraoperatively. So my question to you is, which empiric antibiotic regimen listed below would be most appropriate for TMP? Would it be A. Piperacillin, tazobactam, or B. ertapenem, or C. ciprofloxacin and metronidazole, or would it be D. ceftriaxone and vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Piperacillin, tazobactam. This patient has community-acquired complicated intra-abdominal infection involving the middle small intestine. Although enteric gram-negative bacilli, e.g. Escherichia coli, Klebsiella species are the most common pathogens related to this type of infection, patients with severe disease, as evidenced by concomitant septic shock, are at a higher risk of MDROs, including Pseudomonas aeruginosa and Enterococci. Piperacillin, tazobactam has empiric activity against these organisms, whereas the other regimens or agents listed have relevant gaps in the bacterial spectrum relative to these pathogens. That makes answer A correct. Answers B, C and D are incorrect. Let's move to the next question please. And the next question reads, HPM, a 45-year-old male patient who is a chronic alcoholic presents to your accident and emergency department with a chief complaint of severe epigastric pain. His pertinent lab results include serum lipase greater than 10 times the upper limit of normal. A CT scan is done and it shows necrosis affecting almost 40% of the pancreas, no abnormal fluid collection and no abscess. HPM is a febrile, tachycardic and has an elevated WBC. His urine output is less than 0.5 ml per kilogram per hour, which renders him hypovolemic. So my question to you is, what would be the role of an antibiotic in HPM's clinical scenario now? Would it be A. Initiate prophylactic antibiotic therapy to prevent infection of necrotic tissue, or B. Initiate perioperative antibiotic therapy in preparation for pancreatic debridement, or C. Initiate empiric antibiotic therapy for presumed sepsis and likely pancreatic infection, or would it be D. Antibiotic therapy is not indicated? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Antibiotic therapy is not indicated. HPM presents with severe acute pancreatitis with radiographic evidence of pancreatic necrosis. Although he presents with SIRS, the absence of significant fluid collection or an abscess suggests there is no active concurrent infection. There is therefore no indication for empiric antibiotic therapy now. That makes D correct and C incorrect. Most recent evidence and guideline recommendations don't support prophylactic antibiotic therapy for preventing infection of the necrotic tissue. That makes answer A incorrect. The mainstay of therapy for this patient is volume resuscitation and consideration of surgical debridement of pancreatic necrosis if persistent SIRS is evident. That makes answer B incorrect. Let's move to the next question please. And the next question reads, QPR, a 65-year-old female patient is admitted to the MICU due to very severe metabolic acidosis secondary to unintentional metformin overdosage. Her MICU stay has been complicated by femoral vein CLABSI and related severe sepsis due to pan-sensitive Escherichia coli. QPR received a 3-day course of empiric piperacillin, tazobactam, removal of her central line, and 11 days of ceftriaxone definitive therapy. Eventually the sepsis resolved. After 24 hours, it was noted that QPR had 9 loose bowel movements and new leukocytosis of 14,500 cells per millimeter cubed, which suggests Clostridioides difficile infection, abbreviated as CDI. QPR continues to tolerate enteral nutrition. So my question to you is, which is the regimens listed below would be most appropriate for QPR's suspected CDI? Would it be A. Vancomycin 125 mg per feeding tube 4 times daily, or B. metronidazole 500 mg IV thrice daily, or C. metronidazole 500 mg per feeding tube thrice daily, or would it be D. fidaxomicin 200 mg per feeding tube twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. metronidazole 500 mg per feeding tube thrice daily. Metronidazole orally or through a feeding tube was recommended for management of an initial episode, mild-moderate CDI, but guidelines have since changed slightly. The absence of WBC above 15 × 10⁻³ cells per millimeter cubed and no apparent new increase in serum creatinine suggests this is not a severe CDI. That makes answer B correct. Intravenous metronidazole and vancomycin are indicated for more severe or recurrent cases of CDI. That makes answers A and B incorrect. Data for fidaxomicin use in critically ill patients are limited and should only be considered for persistent recurrent CDI. That makes answer A incorrect. Let's move to the next question, please. And the next question reads, GLP, a 44-year-old male patient is admitted to the SICU following an open total colectomy with ileostomy for ischemic colitis. 4 days after SICU admission, the surgery resident on your interdisciplinary SICU team notes moderate erythema measuring 3 cm and purulent drainage from the wound. He subsequently opens the skin portion of the wound where he finds infected material just above the unaffected fascia. No systemic signs and symptoms are noted. So, my question to you is, which of the interventions listed below would be the most appropriate in GLP's case now? Would it be A. Initiate broad-spectrum antibiotic therapy for suspected necrotizing fasciitis, or B. Initiate empiric antibiotic therapy targeted against skin and colonic flora, or C. Initiate empiric vancomycin for postoperative wound infection, or would it be D. Continue dressing changes and patient assessment? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Continue dressing changes and patient assessment. This patient has a superficial wound infection requiring opening and the local debridement of infected material. Lack of systemic signs of infection and no involvement of the fascia suggest that no antibiotic therapy is necessary at this time. That makes answer D correct and answers A to C incorrect. If the infection extends to include these features or worsened erythema consistent with cellulitis, empiric antibiotic therapy may be warranted. Let's move to the next question, please. And the next question reads, FYI, a 30-year-old HIV seropositive female patient on highly active antiretroviral therapy, abbreviated as HAART, presents to your accident and emergency department with 30% total body surface area, abbreviated as TBSA, epidermolysis of her back and upper arms suggestive of toxic epidermal necrolysis, abbreviated as TEN, likely from cotrimoxazole. Reportedly, FYI arrived at your hospital about 6 hours ago with less than 10% TBSA involvement. Her pertinent vital signs include a heart rate of 142 beats per minute, a respiratory rate of 30 breaths per minute, a blood pressure of 100 systolic and 50 diastolic mm of mercury. So my question to you is, which of the regimens listed below would be the best initial pharmacotherapeutic intervention in FYI's case? Would it be A. Initiate broad-spectrum antibiotic prophylaxis for wound infection, or B. Place a nasogastric tube to administer HAART, or C. Initiate crystalloid resuscitation for hypovolemia, or would it be D. Administer high-dose corticosteroids to halt the progression of TE? And I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Initiate crystalloid resuscitation for hypovolemia. Similar to severe thermal cutaneous injury, the foundation for managing TEN is volume resuscitation and supportive care as well as removal of all suspected causes. That makes answer C correct. The utility of corticosteroids is limited and may be harmful to wound healing. That makes answer D incorrect. Addition of unnecessary drugs that could confound response or worsen the injury, e.g., antibiotics, should be avoided. That makes answers B and A incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 142.